we're looking for someone who wants to tell their story, update us or whatever. Someone like to start that? Peter? We'll take Peter.
Yeah, Jim, just letting you know that I'm scheduled on the 25th of August to be in the Wesley getting an artificial urinary sphincter inserted. At the moment, I'm going through anywhere up to a whole pack of 8-drop pull-ups a day. So fingers crossed it'll work. My urologist has said that he's never had one failure, but he can't guarantee 100%. So that's my next journey.
Can you tell me how that works, Peter? It's Charles here.
Charles, well, I understand they knock you out to start with. They'd want to. I've had a look on YouTube. It looks a bit of a barbaric operation. They make an incision in your perineum and they go up through the inguinal canal. They also then make an incision in your abdomen and place a reservoir in your abdomen. And then that's connected to tubing that has a cuff and it goes around the urethra and then down through the inguinal canal into your scrotum. And there's a little pump no more than that long and about as thick as your finger. And they don't commission it, for want of a better word, for 6 weeks post the operation, just to make sure everything's settled down. Then when you want to have a pee, you press this valve in your scrotum. It relaxes the cuff around the urethra, and you've got about a minute to empty your bladder before the cuff starts tightening up again. So hopefully it'll work, because I want to go traveling around the world again.
So this is obviously for incontinence, right?
Yeah, I came down with, well, radiation caused bleeding from the bowel in 2021, which they fixed with Argon Ablation Therapy. Last year, it affected the bladder, and it progressively got worse to the stage where they did a TERP in October, because mine is stage 4. They didn't want to take out the prostate at the beginning, so they did a TERP. February, I had Botox injections into the bladder wall. That hasn't worked, so this is the next step in the process.
Just a comment, if I could, Jim.
Yes.
Peter, I've had one of those 3 years ago, June, July, something like that, 2020. Similar reasons. Radiotherapy caused incontinence, which was I couldn't control with any exercises or anything like that. And it's been a huge success. It's a real winner. It doesn't stop the leaking completely. I still wear a pad, but one of those number ones that 10
Yeah.
So that'll do me all day and through the night. You know, that's all.
So what's it called again? Sorry.
It's an artificial urinary sphincter, and it's made by a company called Boston Scientific, and I think it's an AMS 800 or something, like some model number like that.
Yeah.
They give you a little dummy so you can look at what's being put in there. It's a full scale model of the thing, so you can see what's gone in. But it's you get used to it pretty quickly. Actually, pushing the little valve. You've got another little button on that gadget that's in your scrotum, which turns the whole thing off, which you obviously need to do if you require a catheter at any time. So, you know, you got to make people aware of that, I guess. But yeah, it's been terrific for me.
Who's your urologist, Peter, at the Wesley?
Dr. Kiosoglos.
Okay, don't know him.
Yanni?
Hi, Pete. What was the Botox supposed to do?
The radiation had hardened the bladder wall, and consequently, instead of holding, that much, it was only holding that much, and it was saying, the brain was telling the urinary sphincter, you need to pee. And it was worse at night at the beginning, but now it just runs out of me. The Botox is supposed to soften the bladder wall to allow you to, hold more urine than you had been previously. But it didn't work.
Because you also mentioned anal bleeding, and
that was from radiotherapy. Every time I went to the toilet, I was bleeding from the anus, and it was some of it was explosive. It would just go everywhere. So the gastroenterologist went in and did Argon Ablation Therapy on it, which basically cauterizes the blood vessels that were affected. And it's worked 100%. There's been no issues. Thank you, thankfully.
because I had quite bad hematuria, bleeding from inside the bladder after I had a prostatectomy and then radiation treatment, and I ended up undergoing hyperbaric treatment for 6 weeks, and that sort of fixed that, because it encouraged new blood vessels to grow all around the inside of the bladder. So I was just sort of thinking about it in that context.
Yeah, no, the terminology is radiation proctitis.
Yeah.
That was really helpful, Peter, because I'm going through, I've had chemotherapy for bladder cancer, and now I'm doing immunotherapy, but my incontinence is getting worse. So I'm seeing my urologist again in probably a month, and going to discuss some of these things. I didn't know about this artificial urinary sphincter thing.
Yeah.
So
one thing I must add, Charles, and it's your call if you want to answer it. Have you got private health cover?
yes.
You do?
Yes.
Okay, well, the main reason being is the prosthesis is supposedly in excess of $30,000.
Okay.
So
You got
your health.
private?
I've got private health cover, and because it's going through the Wesley, which is one of the preferred hospitals for my health cover, they will cover the prosthesis, the hospital administration costs. It's a 2-day, well, according to my urologist, it'll be a 2-day, 2-night, whatever you want to call it. The only thing I'll be up for will be the excess fee that my urologist and anaesthetist charges.
Do you know how much it doesn't matter. Urologists charge different amounts anyway.
No, his fee for the procedure is about $2,100.
Okay.
And I'll be out of pocket about $1,300.
Okay. I go to the Wesley as well for all my treatment. Yeah. With Dr. Grimes, and I've got another urologist, Dr. Navaratnam. So
yeah.
Here's my key ring, the little model of the thing that's in the scrotum I was talking about.
okay.
Press down there. There's a couple of tubes. Can't see it too well.
Oh, this is great, because
tubes coming out there, and there's the other little. Where's the picture? There's the other little button I was talking about that turns off turns the whole thing off. But you just.
This is great, because I thought the only alternative I thought was have the bladder taken out, or artificial bladder. So this is good news.
The only other thing I'd add is that we've got quite a number of people in our group here in Geelong who have had the artificial sphincter, and without exception, they're all wrapped.
Oh, great. Thanks.
I reckon there was one guy, Alan, years ago, for whom it didn't work, but it's like my urologist quoted 95% success rate. So, yeah.
Cool. That sounds great.
Okay, someone else wants to update us, tell their story if we haven't heard it yet.
I've got a little bit I can say, Jim. I haven't been on for a couple of months, I guess, and last one was recorded. Yeah, well, we went through all that embarrassment. But anyway, since I spoke last, I've had a little bit of that whack-a-mole stuff that we talked about a few months ago. Alan, you were on the guacamole front there, yeah. I've had some palliative radiotherapy, which on my right hip and my thoracic spine, not fully pain-free, but pretty good. I was hopeless back in sort of mid-June. I was really bad. So that's good. That stuff that works for me. So that's all I wanted to say. Just whack-a-mole is good.
Thanks. Yes, we have Alan, of course, is a fan of that. Okay, so anyone else wants to update us, tell us the story? Charles, thank you.
I could, give a 5-minute story of my 22 years. I was diagnosed 22 years ago with PSA of 67, Gleason 4+4. I ended up going down to Sydney to Philip Stricker and had high rate brachytherapy, HDR, plus external beam radiation, plus hormone therapy. Initially quite successful for a couple of years, and until I stopped the hormone therapy and my PSA started going up again. Whereas from there, one interesting thing I did back in those early days was I had Zometa, a bisphosphonate, every month. I presented to my oncologist, which was unheard of. Then it was usually just once a year, that to have it every month, and he agreed to do it. And I've had a bisphosphonate every month since. And the one I'm on now is Xgeva, and I think I don't know, but that could have stopped the cancer from going to the bones, because it has gone to the two lymph nodes over time, and I've had pinpoint radiation to those, and that's been quite successful as well. I've tried various things over time after the HDR stopped working. I've had even ketoconazole, which was terrible side effects. I've had estrogen, which caused me problems as well, and thalidomide, which didn't really work. That's the one that used to cause cancer to unborn kids. What else have I done? Yes, I went to, years ago, when the PSA started going up, they couldn't find it with the scans that were available at the time. They didn't have the PSMA PET scans. They were just the full body scans, and they couldn't pick up anything. And I ended up going to Nijmegen in Holland to Dr. Barats, and he did he developed a scan over there, and that was quite good too. That picked up tumor in one of the lymph nodes up in the pelvic region, and I had radiation to that, and that gave me 2 years to disease free. But over the time, I finally got onto enzalutamide, and I've been on that now for 8 years. It's working, but not quite as well as it used to. The PSA started going up a little bit. But late last year, I was diagnosed with, started bleeding from had some piss in my urine, blood in my urine, and had a cystoscopy, and that showed there was cancer. And now that was November last year, and now I've had chemotherapy for that, which coincidentally brought the PSA down as well, I think. And then I'm in 6 months of immunotherapy with avelumab, which the first test seems to be working. There's no sign of cancer, but it does. That's not conclusive. It can be there, but I probably won't have another cystoscopy for another month or two yet to see if it's still in remission. So that's where I'm at, and that's why, and plus that's why I was interested in the in that artificial urinary sphincter, because since being diagnosed with bladder cancer, my incontinence has got quite a lot worse, especially since having that cystoscopy. I think that did something that sort of opened up the urinary tract or something, you know. Anyway, that's where I'm at the moment. So that's why I came onto this this meeting, because I was hoping some guys had bladder cancer as well, and there were some answers there, and already there is. So that's great. Thank you very much.
Thanks, Charles. Anyone, any questions for Charles? Comments?
I think nivolumab's can be pretty effective for bladder cancer. So one of the earlier successes for therapy. Got a good chance, I think. You've certainly been around the traps, though, mate.
Yeah, I even went over to Singapore. There was an American doctor. I was going to go over to America. He's one of the doctors that started the triple androgen therapy, Dr. Stephen Tucker. And he ended up moving to Singapore. And I used to go over to Singapore every 3 or 6 months for a couple of years, and then come back and to Brisbane. And the oncologist was very kind enough to implement his recommendation, which is pretty unheard of, really. They don't like to take responsibility for someone else's diagnosis and treatment. So I was quite fortunate with that, and that's been very successful. Right. I asked my oncologist here, and now years later, what did he think? And he said, well, if you'd done what I wanted you to do, you'd probably be dead now.
That's pretty honest.
Wow. Yanni wants to say something.
Yeah, I was just going to ask Charles whether he was talking about blood in the urine as well, and whether he'd explored hyperbaric treatment.
No. What is that? I don't even know what that is.
Well, that's a chamber that the divers go into for the bends.
Oh, yes.
And so you sit in that for an hour at a time, and it flushes your system with oxygen and encourages new blood vessels to grow. So,
okay.
The problem with radiation treatment is that it makes the blood vessels fragile around your bladder, and that's why I was bleeding. I don't know whether that would be the same for you. And
no, well, bladder cancer was diagnosed. It was quite a heavy dose of bladder cancer.
Yeah. Okay.
I don't know if it would work for that or not.
Before John comes in on that, I'll just talk to that one generally. Radiation damages cells. Doctors aren't too worried about damaging the cells in your bladder and bowel a bit, because those cells have to take all sorts of alkalines and acids all day, every day, and they change to new cells. They grow new cells in about every 2 or 3 days.
Okay.
The problem arises is that those new cells that grow every cell to live needs blood supply. So those brand new cells grow tiny little blood vessels to keep them alive automatically. What happens is that, rough food coming down the bowel, cabbage from sweet and sour or whatever, scratches that surface and causes those little blood vessels to bleed. So just as if you skin your elbows or your knees and you get a scab on it, the first thing that's done is to make a scab that will protect the new cells growing underneath. And one way of that is with lasers. They basically, as someone told us, they burn the surface of those cells to make that scab. Another way is Botox. Another way is, and the most successful way is now I don't remember this, but you preserve insects in this fluid in museums and things like that. Can anyone help?
Formaldehyde?
Formaldehyde.
Formaldehyde.
So they do a rinse out of the bladder or the bowel with formaldehyde and water mixture. And they generally do 3 treatments of that. We had a guy up north, couldn't go out of the house because of the bleeding. And he was in a terrible way. He had came down to Brisbane, had the first of the 3 formaldehyde rinses, and that fixed him up 95%. He was out on the beach the next day with his grandkids, and completely cured him with the 3 of those. The very last one is hyperbaric treatment, hyperbaric oxygen. As Janis can probably attest, you've got to be there at this centre every day for quite a long period and spend quite an amount of time in it. So that's my bit there. Does anyone else want to go back on that question? Okay, people can now mute if they're not talking. Anyone else wants to tell their story or ask further questions? Thanks, John.
Yeah, hi everyone. I won't go, I think I've told my story before, but at a very high level, 6 years ago with very advanced and aggressive cancer, I had a radical prostatectomy. It came back, my PSA went up and I had 36 radiations every day. That worked for only a short time. Then I had radiation again for 3 or 4 lesions in my bowel, in my stomach area, which I now regret because that whack-a-mole thing we were speaking about earlier, it came back only 6 months again later. And at that point, the radiologist and my urologist said, literally used those words, it's like whack-a-mole, it's not going to work anymore. We're going to have to, we'll go on to chemotherapy and ADT. But the reason why I regret it is because I had no incontinence post-surgery, which is pretty rare, and I was very happy about that. It was the one upside, but the second lot of radiation has resulted in fairly bad scarring and incontinence, which is slowly getting worse as I guess the burn continues. But that wasn't really what I wanted to bring up, is that my ADT and chemo sort of gave me about 2 years. And then my PSA started rising and I went on to abiraterone approximately a year ago, maybe a tad longer, which thankfully is still working. Although my next PSA test is next week. And as you all know, every 3 months, I kind of live in 3-month allotments until for the next test. But at some point, I know it will fail like everything else has. And I guess my question is to the group is, I have 2 questions. One's about side effects, but the other one is about when it does inevitably fail. Does anyone have any recommended next steps? I think my oncologist is talking about chemo again and possibly targeted radiation, but we haven't really talked about it at length because we haven't needed to. But given that I've got a meeting next week and who knows what the results will be, it's nice to be prepared with some knowledge. So that's the one question about any recommendations on that front. And the second one, sorry, a dog that's not behaving behind me, is my current medication is basically, continuing of Zoladex and abiraterone, and a few other drugs to mitigate some of my side effects. But every morning I wake up feeling with shocking headaches and quite nauseous, and especially when I bend my head down, and I sort of start to feel better about 2 o'clock in the afternoon. I'm wondering whether anyone else has had anything like that, and whether there's anything that I might be able to do to help with that. So, yeah, they're my 2 questions today. Over to you. Anyone?
Yeah, anyone. Yeah, Alan, thanks.
Just a couple of things. And it's basically collecting data to open up possibilities rather than providing solutions. But there are a couple of other tests which might be worth thinking about. They're basically genetic tests to check whether or not some additional therapies such as PARP inhibitor, olaparib, would be relevant in your case, or whether immunotherapy might be relevant in your case when you're thinking about next steps. I mean, there's nothing like having data first and strategy next. So maybe you should have a chat to your med onc about lining you up with with some genomic panel tests. Whereabouts are you?
I have done a few, the 2 basic tests for brachytherapy gene and what have you. I have done that, and I don't qualify, so to speak.
You haven't got BRCA. The other one is whether you've got the particular gene profile that would suggest that a PARP inhibitor like olaparib might be helpful. It's a minority of people that would apply to, but those that it does apply to, it's very effective. So it's just a possibility worth inquiring about.
I've always liked the idea of immunotherapy, but I was under the impression that it didn't particularly work well with prostate cancer.
Well,
Just a second, please. John? John?
Yes.
Okay.
Yes, I'm here.
The way the technology works is it only sends the video bits that change on your screen, so that usually it's just showing your lips moving and your eyes blinking. If you move your phone around, you're using a tremendous amount of data, and we couldn't hear you properly because it couldn't fit the voice with you moving around. So if you can settle, we'll hear you better and see you better. Thanks, John. Thanks.
Yeah, I didn't realise that. I was only walking around because I was trying to keep the dog under control.
Yeah.
I'm in a holiday. I'm in a caravan park.
Everybody needs to mute. Everyone should mute unless they're speaking. So, John, just to answer your last question, does immunotherapy work for prostate cancer? For the most part, prostate cancer is considered to be, can you hear me?
Yes.
Okay, sorry. Everything seemed to be frozen for a minute. Prostate cancer is considered to be a cold cancer as far as immuno goes generally, but and there's a lot of research going. I'll pass it back to you, Jim. Jim, have you got audio? I think our link is.
Thanks, Alan. I forgot to unmute myself.
That's all right. I got partway through it and then it all went haywire. So,
Hello, Tony.
probably just best if you listen for a moment, Tony.
He can't hear us.
No, okay. So I'll just very quickly finish what I was saying. That for the most part, prostate cancers tend to be, with our present knowledge, cold or a bit unresponsive to immunotherapy, but there's a heap of research going on which hopefully will change that. But there are a couple of versions where it works, and we've already talked about that. It all comes back to genomic testing and taking it from there. So that was your last question, I think, John. Back to you.
Yes, thank you.
Yanni?
And anyone can comment on my side effects, perhaps?
John, perhaps you might consider changing from abiraterone to darolutamide or enzalutamide or something like that, and just see whether that makes any difference.
Yeah, I'd echo that, Yanni. I'd select darolutamide. Would be a good option. It doesn't penetrate the blood-brain barrier like the others do. Enzalutamide and apalutamide do. So whether that's got anything to do with the effect, hard to know, but it's certainly worth exploring with your doctor. Darolutamide particularly.
I think someone asked me before who my oncologist was. Is that right? Well, if someone did, it's Jeremy Shapiro, and my urologist is Mark Frydenberg.
Well, you're in good hands with both of those.
Top people. Peter wanted to ask something.
Yeah, Alan, can I ask you what that last one you mentioned? I'm on enzalutamide daily, plus the ferroline injections every 3 months.
Yeah. Well, I mean, the classic is when you're on a good thing, stick to it. But I
don't like enzalutamide.
No, I mean, enzalutamide can have some effects like blood pressure and fatigue and so on. Fatigue in particular is common with
yes,
enzalutamide. And your option, if that category, enzalutamide, apalutamide, and darolutamide, they're all in the same general class called antiandrogens, and they simply act by blocking access to the cancer cells of testosterone. They just act like the key and keyhole principle, act as a blocker. It just happens that darolutamide is a big molecule and it doesn't penetrate the blood-brain barrier. So if you have any symptoms that are essentially central nervous system related, and obviously seizures and falls and trips and maybe your symptoms, I don't know that for sure, but a switch to darolutamide wouldn't be hard to organise with your doc, and certainly worth a try, I would say. If that doesn't work, then a switch to abiraterone would be an alternative, I would say. It works differently to enzalutamide.
Do you know if it's on the PBS?
Certainly abiraterone or Zytiga is. These days, the restrictions on using it sequentially after an alternative like enzalutamide have been relaxed a bit, but your doctor will he'll have to work out how he talks to the health department about that. Generally, they manage to find a way around it. I think darolutamide just recently was added. It's certainly gone past the TGA. Whether it's got past the health department yet, I think it's been recommended by the PBAC, the committee that recommends these things to the government. Whether the government's picked it up yet, I'm not sure. Do you know, Jim?
Yes, I do. It doesn't really depend on well, it partly depends on your oncologist, but the rules are if you change to a second one, you have to pay for it, unless your doctor says you were actually allergic to the first one.
Exactly.
They are all of them now on the PBS. Once they've been approved by the PBAC to go on the PBS. Once that happens, then all the conditions are in place. It may not be in the PBS website already, but your doctor will be able to prescribe them, and you'll be paid for them, and all that sort of thing will happen. The government has enough money to pay for them always, because in each budget, in their forward estimates, they put in the drugs that are going to be, that may be approved. So it's automatic. The government pays for it. They never have not paid for a recommendation of the PBAC.
The only thing I didn't recall, because normally the health minister likes to get plenty of PR and cameras and TV announcements when they make an addition to the PBS, particularly if it's an expensive item. And I don't remember seeing that for darolutamide, so it may be in the system still, but it's certainly got past the PBAC. So
yes, his or her announcement is irrelevant to whether the people can get the drugs.
Okay.
One final thing on the lutamides and abiraterone. Doctors who aren't very aware take people off those treatments and move them to the next treatment when the PSA starts rising, whereas the studies that support the use of these drugs are based upon seeing extra problems on scans or other clinical things like pain or blockages or whatever. So you don't give them up just because your PSA is going up. The rider on that is unless your PSA rises by more than 50% of its lowest point. But anyway, don't panic your doctor into stopping it because your PSA is going up. You're wise to wait until you've got other symptoms. That's part of a general principle of get as much out of each treatment as you can. You know, if you're going to have 8 treatments and you're getting an extra 3 months out of each one, that's an extra 2 years of life. That's not originally from me. That's how Mark Moyad talks about it. Thanks, Alan.
Jim, I'm going to have to bail, I'm afraid. I've got another commitment which starts in a few minutes. So sorry to have to do that, but I'll look forward to joining the next meeting.
Thank you very much for your contribution, and we're sorry to see you go.
Yeah, me too.
My regards to all those Geelong people, Alan.
Oh, I'll pass it on. Okay, thanks, mate.
Bye. Yes, Tony. Yes, please. Okay. Well, certainly, just because it stops working, you can't have a second one. It's only if you're allergic to it, and that would probably show up in the first 1 or 2 or 3 doses. So I don't think you'd get away with it if you've been having it as long as you have. Remind me, is that 3 years, more years? Yeah, 4 years. I don't think you can kid that you're allergic to it. No. Someone else? Okay, thanks, Tony. Someone else wants to, tell us a bit of their story or ask a question or whatever. Yes, Yanni.
I'm happy to reveal that I'm last blood test, my PSA was still undetectable, so it's now below 0.010, and that's after 5 years on enzalutamide and about 10 years on Degrelix, and I've probably been on triptorelin now for about 9 months, and must say that triptorelin has been much easier to handle than the Degrelix. But in answer to Pete's observations about how enzalutamide is difficult for him to handle, I guess I've been very fortunate that I've just had some fatigue, hot flushes, and nothing out of the normal hormone treatment. So I guess I've been very lucky.
Thanks, Yanni. Any questions or comments of Yanni?
Yeah, Yanni. Yeah. Oh.
Yep. No, I wasn't on Luprin. I was on Degrelix, which is more or less the equivalent of Luprin, except it operates in a different way. For, as I say, about 10 years, and I got too many scar issues where the injections used to go in my belly, so I changed it to triptorelin, also known as diferoline, as the sort of first layer of hormone treatment, and that's worked very well. But I complement that with enzalutamide. So if you're having troubles with Luprin, maybe try diferoline, because my research said that that was the most effective of all of the first generation testosterone suppressant hormone treatments. You can get 1 month or 3 month injections, even 6, I think, in your bum.
Yeah.
TRIPORLIN or diferoline. Say again. TRIP trip R or ORLIN. Yeah. Triptorelin.
Jim here. From now on, we won't spell out things over the Zoom meeting. We will either find them in the chat. So if you can easily reach chat on your device, you'll see that I've put some stuff that we've been talking about up on the chat. or I will undertake. I'll take a note and undertake to send the details to whoever it is. Yes, I've made a note of that. Sorry, Tony, I've made a note that I'll send that to you. That chat won't be part of the final video, YouTube video. Okay, on the last meeting, I did, for people who were viewing it, I did put those drug names on the screen, so we're aware of that. But anyway, good luck with that, Tony. Yes, Tony Maxwell. We know that, Tony. Thanks, Tony. If you want to speak, put your hand up so we can see you. Right. So, anyone else with any comments, questions on anything that's happened so far today? Yes, we'll start with Peter. I think he beat Charles.
I was going to ask Janis, because he's been on the enzalutamide for 4 years. I've been on it for 18 months, but it seems to have hit me like a sledgehammer. I've got no energy whatsoever. I've got to have a nano nap every day. And now I'm finding, it might seem a trivial thing, but my fingernails keep on chipping. I don't know whether you've had a similar issue. Oh, yeah, no. you can laugh, Jim, but you can be working in the garden, all of a sudden your whole fingernail's broken off.
Yes. I've got about 8 different kinds of pairs of gloves for different activities. But sometimes I get away with just the 2 Band-Aids, one over the top and one round it, until that one, fixes up a little bit. Yeah, right.
Well, I've been looking like somebody from grade 5 who bites their fingers all the time.
Yes, as we all.
So did you have any issues like that, Janis?
Yeah, my fingernails are quite soft and they chip easy, they tear rather than chip, I guess. But I try and make sure that they're cut short so that they don't catch on stuff. And that's how I get around that. But in terms of the fatigue, I've been, whilst I've been naughty and haven't maintained an exercise regime over the last few months, because we've moved house, I have been pretty busy. And I've found that the more active you are, the less fatigued you get, which is sort of a bit counterintuitive, but that's my experience. I have noticed, though, with enzalutamide that my hot flushes are a bit worse than they were with Degrelix, but my hot flushes, I guess I don't experience them too much during the day, but I do during the night. And just because, that's one of the good things about Melbourne. It's damn cold at the moment. So you just toss off the blankets and hang in there for about 5 minutes. And when you start to feel cold, you put the blankets back on. But it's been pretty manageable, really.
just to let me finish my show and tell, I have 5 of these. I have one at the desk I've just picked up. I have one on the table behind me where I eat. I have one in every room. They're designed to take out staples. It's a staple remover. But when I want my grandsons to bring me one, I say, bring me my fingernail. And I use this for things that need fingernails because my fingernails, can't open things or whatever. Anyway, but I'm sure other people got something to contribute on the fatigue, perhaps. Other than that, Charles was about to offer something earlier.
Just on the enzalutamide, as I said, I've been on that for 8 years. And when I was first on it, I had side effects mainly with digestion, and I found that the stools were very sticky and quite yucky. Anyway, but it was very effective in bringing the PSA down from 150 down to under 1 quite quickly. And I talked to my oncologist about changing the dose from 4 a day to 2 a day. And he couldn't see why I could try that, and I did. That helped a lot, but it was still effective. Over time, over years, it became less effective, and I increased it to 3 a day, and without very much, the side effects I seemed to tolerate the side effects better until I put it up to 4 a day again, and still I handled the side effects better, over slowly increasing it. So maybe something you could talk to your oncologist about, see whether he'd be interested in seeing whether he'd let you decrease your daily dose.
Well, I actually started on 4, couldn't tolerate it. He dropped me to 3. It was still an issue. He's dropped me to 2.
Okay.
But the PSA has just started to rise, just that fraction. Yep. I go back to see him next Tuesday, so fingers crossed the PSA is stabilised and I can stay on 2.
Okay.
The higher dose I just couldn't handle.
Yep. No, I couldn't either to start with, but I do now. That was all I had to say.
Okay. Anyone else with an update, a question, contribution? Tony Maxwell.
Just a little bit more on enzalutamide. I've been on it for 8 years now, and I was originally on Leukeran. I'm still on Leukeran as the original ADT. I've always suffered from fatigue. That's been my major side effect. The enzalutamide made that a little bit worse, but I'm always been on 4 a day, and I've been able to tolerate that in spite of the fatigue side of things. And I'm still on 4 a day at the moment, even though I've had the spot sort of radiation, which seems to have dropped my PSA down very substantially in recent times. So I've been on, as I say, I've been on enzalutamide now for about 8 years, and generally the sort of profile of side effects varies from person to person, I think, from all the talk I've had from people. And it's a slightly different mix for everybody, but I think we can, it can be adjusted to a tolerable level. Eventually it will fail, probably. I think mine started going up again, and that's why I did the radiation, which has been quite successful so far. So, yeah, just a little bit of extra information about the enzalutamide.
Yeah, I agree with all that.
Jim?
Yes, Tony.
Tony S here. Can I speak?
Yes, please.
I asked my oncologist about that question of, well, could I go to another drug if we think that Xtandi is not working anymore, and he just gave me a flat no. You're
Okay.
saying to me that if he claims that I was allergic to it or something, then I might have a chance.
Well, certainly, just because it stops working, you can't have a second one. It's only if you're allergic to it, and that would probably show up in the first 1 or 2 or 3 doses. So I don't think you'd get away with it if you've been having it as long as you have. Remind me, is that 3 years, more years?
Going on 4.
Yeah, 4 years. I don't think you can kid that you're allergic to it.
Yeah, I don't think that's an option for me.
No.
Okay, I just thought I'd make that comment.
Okay, thanks, Tony. Jani?
Yeah, I did. I thought it was fantastic. I thought, yeah, it's Jani. Yeah, I thought it was fantastic. It there were 3 groups of speakers, and as you know, I guess, Tony, they spoke about neuroendocrine cancer and how they've identified something called DLL3 and a zirconium treatment that might disrupt the cancer there. And then in the alpha emitter space, I took notes. And in the alpha emitter space, they identified surprisingly that as opposed to lutetium 177, that which has a sort of a 10 millimeter penetration to cancer cells, that if they used lutetium 212, it had 1 millimeter penetration, so didn't damage cells adjacent, but it was 1,000 times more powerful. But the interesting thing was that a lead 212, a 212 PB treatment is coming up as being a very, very interesting possibility. And they produced a chart comparing the pros and cons of all of these various isotopes, which made for very interesting reading. And I took a photo of it, so I'm happy to forward that to Jim if you want.
Thank you.
For those guys in Brisbane, this oncologist by the name of David Patterson at the Royal Brisbane is planning a trial with PB 2112 in a dose escalation study, they're only going to limit it to 18 patients, but if you're in need, it might be a really good thing to try and get onto.
Thanks, Jani. Tony?
I watched it too, Tony Maxwell, and agree with everything that Jani just said.
Okay.
Can I just ask if that link to that conference is available on the last your last post, Jim? Is that what I heard?
The conference has happened. They haven't published it. Those of us who couldn't make it are hoping that it'll be published usually after a week online.
Okay. Thank you. I actually need to go now, but thank you very much for another good session.
Okay, John, thanks for your contribution and cheerio.
Thank you. Bye-bye.
Bye-bye. On those isotopes, there are something like, I've forgotten my chemistry, but something like 69 metals, and many of them have a number of isotopes. So I went to a theranostic conference back in 2014, and there are about 30 different metals and their isotopes that people were using around the world. The reason that they're looking to change, of course, is that the lutetium one, and especially the bit that holds the lutetium to the PSMA, went to a company that's putting the price up. So they're trying to find another one. There are plenty of them around, but you've got to have a trial with people in it and show that it works before the FDA or the Australian government will pay for it.
I think also the issue, Jim, is that the place in the States who used to make it has stopped making it, so it's only now available out of Germany.
Right.
But anyway, I've just emailed you the that thing, so that chart. So
okay, thanks for that. Yes, I will do. I'll make a note of that.
This is Charles. I'm going to go now too. I'll see you all next week. Thank you very much. It was great. It was great information I had.
Okay. Cheerio, Charles.
Bye. Bye-bye.
Bye-bye, Tony. Oh, no, Tony's going to speak. Sorry.
Yeah. No, just I think I got an email about the theranostics thing that we watched, saying that there was something already published. I'll dig through my emails and see if I can find it, and I'll send it through to you, Jim, if I do find it.
Would appreciate that, Tony.
Okay, fine.
George?
Hello, yes.
We just want to say good day. Is there anything you needed to tell us about how you're going?
Right. Well, I'm still having Zoladex once every 3 months, and that's keeping the PSA rate down to undetectable levels. But I've had a ultrasound, and it's saying that the bladder is not fully emptying as it should be. So in the next month or so, we might have a little bit of investigation and have a look inside there to see whether there's a bit of scar tissue in the urethra from the brachytherapy.
Okay. Sounds innocuous.
Well,
down your willy.
Yeah. A bit of a rush trip in to see Dr. O'Neill last night while he was in Dubbo at the private hospital, and it all happened over 10 minutes or so, and we decided, well, that's what we'll do.
Yeah, wise idea to investigate, absolutely, yeah.
Yeah, well, he said it could be that over time it'll keep kind of closing off, just due to that radiation there. Are they still doing brachytherapy?
Yes, but the extent of it has been reduced by COVID.
Right. It sounded from him that I think he was calling it HDR, which might have been high density radiation. It sounded as though they've kind of picked up quite a few people that have got a fair bit of damage from it. And they mightn't be doing it as much, but I didn't have time to ask him all that.
Okay, no, you got that back the front. High dose rate brachytherapy causes less damage than any other treatment. Fewer side effects and keeps you alive longer. If you are high Gleason score, if you've got a Gleason score of 8, 9 or 10, you'll live longer with high dose rate brachy and fewer side effects, says he, sitting here with fewer side effects. I just got it by accident. didn't know it. Well, they didn't know for sure it was better in those days, but the studies have been done now. And the only reason COVID, the trouble is it's often high dose rate brachy boost, which is ordinary radiation sessions after the high dose rate brachy to clear up things that are maybe just outside somewhere. That they closed down all procedures that took too long, and that was one of the ones they closed down. So instead of it, they started using ones where they turn up the dial on the radiation machine and give you fewer doses. Now we know that that's equivalent to high dose rate brachy over 7 years. That's as far as the trials have gone. But we don't know about the 20 or 30 years that we know about brachy for. And some of the problems come up later than 7 years. So another reason for turning up the dial and using stronger doses, because you only need fewer of them, and as few as 5 doses, and you can have them every second day. So if people are a long way from a radiation centre, that really suits. And the final problem is you need really expert teams to do high dose rate brachy, and there's only a few of those around the country.